as in this case, is because of vascular invasion. Did you look for vascular invasion, Dr. Maporna?
Yes, sir.
Yes. Did you find it or not?
Sir, it was not present in the case.
It was not present. Yes, yes, good. So it was not present. So one must look for vascular invasion, and because vascular invasion can lead to, what do you think will happen if there's vascular invasion?
Sir, it will be the disseminated form of the infection.
Okay, okay, good. But what happens once the fungus invades into a blood vessel? What's the sequence that occurs once this happens?
So it can spread to.
Okay, it can spread. Locally, what happens? Locally, what happens? So it's going to elicit a thrombotic reaction, right? And then it will produce thrombotic occlusion to the vessel and cause ischemic necrosis. This is what we saw in a lot of cases due to mucormycosis at the fag end of the pandemic. Remember? I'm sure you recall those, yes?
Yes.
So vascular invasion can also occur in Candida and aspergillosis. Okay, let me conclude by showing you a few slides. This is an aspergillus ball that can occur in empty spaces like the cavities in the lung, paranasal sinuses, and notice these tangled masses of hyaline. They're not pigmented, they're hyaline molds, and sometimes you can get them a little broader, looking like mucor, as you rightly pointed out. But this is because it is going to develop into a fruiting body. You can see a fruiting body here, also known as conidia. And here you have another image of a fruiting body with the conidia, known as conidia. And again, look at this slender forms, which are the native forms, and when it becomes a fruiting body, how broad it can become. So they can be confused for mucor if you look at only those areas. And right, as you said, we can do other stains like Masson Fontana for the pigmented fungi. You can also do a PAS, as you can see in this image. Most likely, chance that you will see this in dermatophycosis as seen here. So yes, very good presentation. You rightly pointed out that this is a fungal infection producing granulomatous inflammation. For further reading, look up this article, Histopathological Diagnosis of Fungal Infection in the 21st Century. This is a 30+ article, which is very good for all the descriptive aspects. Please download this. It's available free on the internet. And then another article which can help you with pitfalls and challenges is this one, which is provided free for you again in the journal Anatomic Pathology. So thank you all. I'll move on to the second case. Thank you, Dr. Maupanda.
Thank you so much, sir.
Yeah.
Dr. Rajamina, please share your screen and case number 2.
Yeah. Good afternoon to everyone. I'm Dr. Rajamina, first year postgraduate from Akash Institute of Medical Sciences and Research Center. Our college was allotted the second case. The history was 48-year-old female with history of headache. MRI showed falcine encapsulated moderately vascular tumor. This was the mounted view, which shows areas of hemorrhage along with few deeply basophilic areas, which can be the meningeal tissue. Under the 2x scanner view, there were areas of hemorrhage along with thickened blood vessels, which were also present, and there were some spindle cells which were intermixed with these blood vessels. Under the low power, many thin wall capillaries were noted. These capillaries were lined by a monolayer of endothelial cells. These are the same capillaries where we can see the monolayer of the endothelial cells. And there were many small and large vascular channels. These vascular channels were more predominant over the meningothelial components. So these are the tumor cells which were arranged in a syncytial pattern. The individual tumor cells were uniformly spaced and they were round to spindle shaped along with indistinct cell borders. They had open fine chromatin and inconspicuous nucleoli. Few were having a hypochromatic nucleus and moderate eosinophilic cytoplasm. So there was mild nuclear pleomorphism. These in the background, we could see the hyalinized blood vessels and some inflammatory infiltrate, which was predominantly comprising of lymphocytes. So to summarize the findings, section studied shows a meningeal tissue with hemorrhagic areas. Under low power, the tumor cells were admixed with small and large vascular channels. The tumor cells were arranged in sheets in syncytial pattern and with congested thin-walled capillaries in between these cells. Uniformly, evenly spaced meningothelial cells were seen with indistinct borders, bland nuclear cytologic features, fine open chromatin, and inconspicuous nucleoli. Occasional hyperchromatic nuclei were also present. Hyalinized blood vessels, along with inflammatory infiltrate, comprising predominantly of lymphocytes, were seen. So, my final diagnosis was angiomatous meningioma. It is actually a variant of meningioma classified under WHO grade 1 tumors. Here, there was presence of vascular component in a background of ordinary meningioma. So, this vascular component should exceed about 50% of the total tumor area, and it is clinically evident in the middle age. The differential diagnoses were hemangioblastoma and hemangiopericytoma. Thank you, ma'am.
So we will just go through the starting part once again. If I would like to just point out few things. A 48-year-old female patient presented with headache on and off, dull aching types in 6 months. On the MRI brain, it was given as enhancing extra axial mass involving the mid falx and measuring 22 into 35 into 24, and it was opined as falcine meningioma. Now the point is, while reporting any CNS tumors and the bone tumors, we should always make sure we always correlate with radiology report, because in these kind of tumors, the site, the anatomical location, and in which layer they are present, that gives us, it will do the 50% of the work for us, because we know where it is arising from. You will have your DDs always. So it's a extra axial mass involving the mid falx. So they are the main points here. And then on intra-op findings, it was well encapsulated for moderately vascular mass. It was received in multiple pieces, gray white irregular, and the entire tissue was submitted. So microscopy, as Dr. Rajmina already pointed out, the same findings. Now I would like to just go with, it was a cellular neoplasm. Basically, the cells were plump, spindle to oval, eosinophilic to vacuolated cytoplasm, indistinct cell bodies, arranged in vague lobular. So if you see here, arranged in vague lobular and whorling pattern at places, you can see. Okay. Majority of the areas were, it was a vascular component was there, small to medium sized vessels and large thick walled vessels were there. And the nuclei are pleomorphic, hypochromatic and syncytial forms. There was no, now coming to the negative findings, there was no evidence of necrosis present for the evaluation of brain invasion. So now, see, these negative points give us the idea that it is not going into any anaplastic differentiation or anything like that. Okay, so the impression was angiomatous meningioma, WHO grade 1 tumor. So these are the images. This is the vascular component that we are seeing predominantly, and these are the cells. If you see, these plump spindle cells. So now the main point, we did immunohistochemistry on this case. We did a very limited panel. So the cells were positive for these spindle cells. The stromal, that spindle cells, whatever you are seeing, they were positive for EMA and PR. And then CD34, it highlighted vascular component, and the STAT6 was negative. So STAT6 negative rules out your hemangiopericytoma, and PR positive, it rules out hemangioblastoma. Then the impression was consistent, and the Ka67 was 1%. Usually in WHO grade 1 tumors, usually the Ka67 will be 2 or less than 2%. So here in our case, the Ka67 was 1%. Impression was given as consistent with original HND diagnosis of angiomatous meningioma. Coming to the discussion part, these are there is meningiomas are the tumors that arise from meningothelial cells. They can be either intracranial, intraspinal, or orbital. The common sites are being cerebral convexities, and in our case, the site was from falx cerebri, which is one of the commonest site, mostly seen in middle to later adult life. And these meningiomas, these combined of about 15 subtypes of morphological subtypes are there. It's a single tumor subtype with 15 morphological subtypes. Okay, so the CNS WHO grade is most useful histopathological predictor of recurrence. Even among CNS W1 tumors, the presence of some atypical features increases the risk of subsequent progression or recurrence. This is the importance of giving out the negative findings always. Yeah, and the malignant histological features are associated with shorter survival times. R-type, it's a rare variant. Dr. Rajmina has already mentioned all the findings, and the main IHC profile was the most sensitive marker is a SSTRA, somatostatin, receptor 2A, EMA or MUC1, S100, and PR. K67 is either 2 or less than 2. So this is the one point I just wanted to highlight. The recent WHO CNS 5 WHO edition 5, there is a change. The grading system is reformed to grading within the tumor. So earlier, how it was, like we had particular subtypes which were under WHO. If you see that kind of morphological subtypes, you would grade it as grade 1, grade 2, or grade 3, like that. For example, the papillary and rhabdoid were by default they were graded as grade 3, but now they have removed that, and now the grading is purely based on what are the findings you get in that particular tumor. Like I mentioned, if there is any atypia, presence of necrosis, or apart from the typical morphology, if there is formation of solid sheets or solidness, all those things. In 2021 update, it deviates from previous system by including number of molecular factors also. For example, presence of third promoter region mutations, CDKN2A are now diagnostic of grade 3. Then the presence of rhabdoid and papillary subtypes are no longer independently diagnostic for WHO grade 3. Okay, and the tumor location is strongly associated with mutation spectrum. This is also one of the recent findings. This is just whatever I just explained, the same thing. So finally, the take-home message is a proper clinical history, anatomical location, and the extent. They are must for a definitive diagnosis. IHC is always useful. Recent reforms, there are many recent reforms in the grading, so it's very important we update. And then their molecular testing should be considered always, because the molecular features, they have prognostic significance in cases of meningiomas. Thank you.
Sir, am I audible?
Yes, audible, and the screen is also visible. Please go ahead.
Good afternoon, everyone. I'm Dr. Rachita Nahar from JSS Medical College and Hospital, Mysore. We've been allotted case number 3, slide number 6. This is the history which we have provided with.
Close to the mic so that your audio is clear.
Sir, is it audible now?
It's better now. Go ahead.
Yes. 55-year-old male with query sebaceous cyst, query implantation dermoid, right ear lobule, excision biopsy. Just off the scanner view, I'd like to say that the section studies show 3 bits of skin, and 3 bits, which out of them, 2 of them showing the skin. The epidermis seems to be unremarkable, and the dermis shows a well-circumscribed tumor arranged in lobules. Then coming to a higher power, the tumor shows multiple lobules of scattered small basaloid cells and mature sebaceous cells. The basaloid cells have a hyperchromatic nucleus and a scant cytoplasm, and the mature cells have a vacuolated cytoplasm. The basaloid cells, if you just see in this view, the basaloid cells are outnumbering the mature sebaceous cells, which is clearly visible. Some cystic areas are also seen. Just to summarize the entire slide, sections show a structure of skin. The epidermis is unremarkable, and the dermis shows a well-circumscribed tumor arranged in lobules consisting of multiple clusters of small basaloid cells and scattered mature sebaceous cells. The basaloid cells have a hyperchromatic nucleus and scant cytoplasm, whereas the mature sebaceous cells have a vacuolated cytoplasm. The baseloid cells outnumber the mature sebaceous cells. Few cystic areas were also noted, and there's scattered mitosis, which is present in the slide, but without any atypia. So my final diagnosis is sebaceum.
Yeah. Thank you, Dr. Rachila Nahar, right? Yeah.
Yes, sir.
I think
Thank you.
you had a very good presentation. Actually, shared all the points which I was supposed to do it. Okay, that's great. Okay, thank you so much. And let us discuss something beyond what you discussed, right? So I'll not go into the detail because we have all the details which have been discussed, right? The only thing is because the differential diagnosis is also implantation dermoid, so patient was asked to excise that particular tissue, right? So this is what the gross findings. Yeah, this is what exactly you discussed, right? So I have put it in the, these basiloid cells in the blue color. You can see this basiloid cells blue because everything looks blue because they take a lot of hematoxin. Okay, so some people, put it as blue tumor in some word of the old textbook if you see, because it is the basiloid cells will take up so much hematoxin. They look blue everywhere, like ink, right? So this particular lesion, what you see is a lobular structure. You can see a lot of lobules here, one more lobules here, right? And there's a small cystic area in between what you described. And what are these immature sebaceous cells? Most of the immature, wherever you take any of the agnosal tissues, okay, if there are immature cells from any of the agnosal structure, they look basiloid. That's the reason you see a lot of, whatever the agnosal tumors, they'll have basiloid cells also along with that. Okay, I'll come to that later. Yes, as you said, predominantly cells are basiloid and they are admixed with several sebaceous cells, very cleanly, very neatly seen. What is important is the negative points. Again, what Dr. Kurti also told in this Harmy discussion, that there should be a negative points in each and every slide, like no significant nuclear atypia, myotic figures, no tumor necrosis. Okay. Of course, there are some fine fibrous septa you can see here moving all around. So see these blood vessels, fine. That's also you must have observed, right? And basically, what we're looking at is that these tumor cells are bland. Absolutely, they are bland. There is no evidence of either dysplasia, severe dysplasia, or any anaplasia, or there's any necrosis. Okay, so it's basically a bland. So that means we are looking at a very benign looking lesions, right? Same thing to show more of abundant vacuolated cytoplasm, ovoid nuclei, and scalloped nuclear membranes. Look at these membranes. They are scalloped because of the secretion. Even if you want to do, you can do oil red O-stain to demonstrate oil presence in these, sebaceous cells, the mature ones, right? This is the area of cystic lesion containing secretions. Yes, our diagnosis also sebaceous epithelium. But what is the importance of this particular thing? If they are in multiple, suppose you have multiple sebaceoma all over the face or neck, there is something we need to look at, right? Let us discuss that. The benign adnexal neoplasm showing sebaceous differentiation, okay? So epidemiologically, what it's a rare sebaceous lesions may be associated with Muir-Torre syndrome. That's the thing where there's nothing but hereditary non-polypoid colorectal carcinoma syndrome, where we have to be very, very careful, okay? Because the reason that they may harbor any cancer that is usually the colorectal cancer. That's why it is gained some importance. So any tissue, any lesions in the body, we have to give some thought. Example, we can say, oh, it's sebaceous bit-pity, it's okay, fine. No, you should see, ask the clinician whether he has got multiple lesions. Because clinician will not be bothered at times, right? So if you have associated multiple lesions along with this particular lesion, then you should, talk to the clinician exactly whether you are looking at some, this more Torre syndrome or the hereditary non-polypoidal colorectal syndromes, that you have to mention to the doctor or the clinician and ensure that whether we need to do further investigation. That is the importance of this particular lesion. Okay. So localization is face and scalp. Rarely you can see also in trunk and extremities, right? So this is the clinical features. Basically, the solitary yellowish, tan to orange. If they're multiple, then you have this hereditary non-polyposis colorectal cancer syndrome, which you have to be very, very careful. It runs in heredity, so you must see whether other members of the family also have these particular lesions. In some of the lesions, when you do a biopsy, also we can do microcirculatory instabilities, so can be identified. And with this, if you can identify this in the tumor cells of the lesions what you've excised, you might have to do a further follow-up of the patient to rule out whether he has got any lesions in the colorectal region. That's up to leave up to the clinician to take a decision. Sometimes 90% of the germinal mutation in MSH2, that's nothing but the one of the proteins of MMR. What is MMR protein? It's nothing but the mismatch repair gene protein, right? That can also be identified. Now there are some morphological variants which you can see in this. Okay, maybe reticulated, rippled, kind of a variant where you see commonly in the scalp there are bacillite cells in the linear rows parallel to one another, resembling like varicose bodies of neural lymphoma. Sometimes you may, in a hurry, you can make a diagnosis of neural lymphoma itself. That's one thing. Second, we have cribriform variant. See you like having holes, like what you call Jerry in Kannada, right? So that kind of a picture also we can see. I don't have a photograph of that. And usually what we can also see is a glandular pattern, right? So these are the other variants where you can have a differential diagnosis of other lesions as well. Now, coming to the discussion about the differential diagnosis, yes, it is a clear-cut case of sebaceous tumor, but we have to rule out certain things like whether we're dealing with sebaceous adenoma, which is more proportion of mature sebaceous cells compared to the bacillite cells. That's how the differentiation happens, right? Sebaceous tumor is often larger in size, in depth, and morphologically it overlap may be present at times in any of the lesions. So that's how we differentiate between sebaceous adenoma versus sebaceous tumor. So in sebaceous adenoma, what do you see? More of mature
More
sebaceous
of
cells,
mature.
more number of mature cells than the immature cells of the bacillite cells, what you've seen in the sebaceous. That's number one. Number two, in sebaceous carcinoma, again, in any carcinoma, what you should see is ATPR, you should see increased mitotic activity, maybe there's some amount of, local invasion. All this should be there to call it a sebaceous carcinoma. Sometimes patients, or the doctors rather, the doctor will tell you, so this is a long-standing, I want to do out carcinoma, sebaceous carcinoma. Can you do me something? So if you have any suspicion of any of the lesions, any part of the tumor, you can do EMA and P53. If there is a malignant change, they will be more highlighted compared to the normal other, glands. Okay, so this is important if you want to make a very early diagnosis of sebaceous carcinoma. Otherwise, immunohistochemistry has no role. Then coming to basal cell carcinoma, because somebody has given me a differential diagnosis of BCC with sebaceous differentiation. Can anybody tell me how to differentiate between these two? Basal cell carcinoma versus the sebaceous adenoma? Yes?
So there has to be a peripheral palisading pattern, firstly. Mostly
Yes,
people
very good.
like that. And secondly, sir, there's a clefting artifact between the stroma and the tumor because of
Yes.
mucin being there. So that doesn't
Yes.
get, that appears as a clefting artifact.
Yes. Anything else?
Not, sir, also stromal reactions are very common sometimes.
What is the distribution of sebaceous sites? So distribution of sebaceous sites in case of basal cell carcinoma is only very focal. It's not distributed like in all over the tumor, like what you see as a sebaceous adenoma or sebaceoma. Correct? That is the one important part. And sometimes, as you see in basal cell carcinoma, you also see little amount of mitotic activity. Okay, these are the few points where you can differentiate. But if you want to really make a diagnosis with use of immunohistochemistry, you can use BER-EP4 marker. Okay, it's very specific for basal cell carcinomas. Now coming to last one, the sebaceous hyperplasia, the proliferation of sebaceous cells around a clear-cut hair follicle. So you want to make a diagnosis of hyperplasia, you must see the cross section of the hair follicles. Otherwise, you don't make a diagnosis of sebaceous hyperplasia. That's a very important point, and that has to be kept in mind. Instead of making a diagnosis of sebaceous or sebaceous adenoma, if you get a cross section of the hair follicles, then your diagnosis will be sebaceous hyperplasia, because around these hair follicles you see the proliferation of these sebaceous, mature sebaceous cells with maybe very minute or few immature basaloid cells, right? So again, as I said, immunohistochemistry has a very limited role in suppose somebody does say small biopsy. It's rather difficult because you get only basaloid cells. You don't get occasionally you may see one or here these mature sites. So what happens? You're in a dilemma at that time. Probably you can use a negative beer blood EP4 as one of the important marker for a small biopsies. If you get those superficial biopsies, that is one of the important point for a differential diagnosis, and also to rule out the diagnosis of BCC. Of course, in all these, if it is multiple, you must do MSI panel, that is microinstability, satellite instability, that has to be done for all the lesions. That's to make sure that there is no MMR defect. Number one. Number two, rarely you can use, as I said earlier, EMA or P53 in suspected cases to highlight cancer cells in a benign lesion. Okay. So these are the references what I have taken, right? And thank you so much. And if there's anything that we need to discuss, please go ahead. Anybody can ask me any questions regarding these lesions.
No questions in the chat box as of now, sir.
Right.
Delegates may post their questions on the chat box so that we can post it to the faculty.
Yes. I think it's a very simple case because this is one of the cases we have put forward for the junior pathologist so that they learn more about these, small biopsies, how to, handle them, and what are the other, the MSI and all those things we need to keep in mind for these kinds of small lesions also. Right? That's why we have put it across to the this particular slide. So thank you so much. If there are no questions, I think we will go on to the next slide, right?
Yes.
Am I audible?
Yes, audible. The screen is visible. Please go ahead.
Okay. Good afternoon, everyone. So I am Dr. Gayatri Jijo from Kodagu Institute of Medical Sciences. We were allotted the case number 4, slide number 7. And the history is female aged 49 years with history of irregular bleeding per vagina, cervical polyp biopsy. So under scanner, we can see that the section study shows fragments of ectocervix, which is lined by stratified squamous epithelium, and endocervix, which is lined by simple columnar epithelium with multiple Nepothian cysts. Under higher power, we can observe the ectocervix epithelial thickness extending into the endocervix with intact basement membrane. We can also see lymphoid aggregates and lymphocytes infiltrating the stroma.
Dr. Gayatri, you're no longer sharing the screen. Please share again. Right, show more than
It's
yes, it is visible.
So we can see the fragments of ectocervix and endocervix and multiple Nepothian cysts. Then in this, we can see that the ectocervix epithelium shows full thickness dysplasia, which is extending into the endocervix with intact basement membrane, and also lymphoid aggregates and lymphocyte infiltrating the stroma. In this epithelium, cells are shown cytopia, scant cytoplasm with increased nuclear cytoplasmic ratio. Occasional mitotic activity is also seen. So to summarize, section study shows fragments of endocervical and ectocervical tissue, and endocervix shows multiple Nepothian cysts, chronic cervicitis, and focal areas of full thickness dysplasia extending into the endocervix. The differential diagnoses are high-grade intraepithelial lesions and or grade 3 cervical intraepithelial neoplasia and transitional cell metaplasia. Thank you.
Okay.
Okay.
Okay. So the history sent was a cervical polyp. So it was basically an endocervical polyp and the gross had mucoid material. So Gayatri, you were talking about ectoendocervix. Whereas if in an endocervical polyp, we do not get any ectocervix. All that we get is a endocervical polyp, and the whole thing is an endocervical lining epithelium, right? But you were mentioning about the ectocervical lining epithelium. So that is one correction. It was a polyp. It was all having the mucin secreting epithelium. The stroma was fibrocollagenous. There were some lymphocytic infiltrates, and there were some areas of squamous metaplasia. And we saw these kind of areas. See, the whole thing here, this is all the endocervical glands, the tall columnar glands with the basal nucleus, the apical cytoplasm. Whereas here in this strip, you can see that there is some thick and something looking different. So we are now focusing on this area, and see here, it is very dark. The minute you see very darkly stained cells, you have to think of dysplasia. So this is, again, see the surface lining. The lining is endocervical only, the columnar. It is not squamous. So it is not the ectocervix. The whole thing is an endocervical polyp. And the surface epithelium, as well as some of the underlying glands, they were showing this kind of thickening, dysplasia, hyperchromasia, loss of polarity, and it was extending down to the gland. See this gland, partly it is showing the normal columnar, partly it is invaded by this dysplastic epithelium. So also this gland. So that is how we have to interpret this. What about this lining here? This lining, you can see something going down. Can we call this invasion and say it's an invasive carcinoma or a micro-invasive carcinoma? No. This is nothing but the endocervical gland itself, where the epithelium is replaced by the dysplastic epithelium. Look here, it's very clearly seen here. This surface, which has become dysplastic, it is coming down to the crypt, and it has involved part of the endocervical gland. Here, the entire endocervical gland is involved. So this is the clue to telling that this dysplasia is going deep into the crypt, and it is not a stromal invasion. And look here, even more higher magnification, you can see now the nuclei very nicely. They are so dark. And polarity. So for the first year PGs, I want to explain the term polarity. It means orderly maturation of the squamous epithelium. Are you seeing the orderly maturation? No. It is all haphazard. It is all irregular. It is in random. It is polarity. You can imagine the fish. They will all be moving in the same direction. That is polarity, polarization. Here, that same direction is lost. So, loss of polarity, very important feature for dysplasia. Now, the diagnosis received from PGs, we receive a lot of differentials like microglandular hyperplasia. Here you will find mainly the glands, whereas here we do not see the increased number of glands. So that's ruled out. Basaloid carcinoma. Carcinoma is ruled out. I told you these are all invading into the crypts. It is extension. It is not a stromal invasion to call it carcinoma. Hence, all these carcinomas are ruled out. Adenocarcinoma, transitional carcinoma, squamous carcinoma, all these are ruled out. In situ carcinoma, yes, I agree. It's a good differential diagnosis. Urothelial carcinoma in situ, not a very common occurrence in the cervix. So rare things, you will be rarely right. So I think we'll stick to the more common things. And dysplastic endocervical polyp, yes, correct. But I think it's not a very good pathology description to give it an impression. So these were the difference, and the highest number of response was CIN3 bar HSIL, and that's really a good sign that most of you are on the right track. Our diagnosis, endocervical polyp with high-grade squamous intraepithelial lesion, HSIL. Important to note, cytology terminology, histopath terminology, for both we use two-tier system only, LSIL, HSIL. It has better reproducibility. That three-tier earlier system of CIN 1, 2, 3 is now outdated. So please write LSIL, HSIL only in your histo reports as well as cyto reports. if you want to still communicate, in the bracket you can write this is the old term like that. Then briefly about P16. In this case, we haven't done P16, but it is an important marker. It's a surrogate marker for HPV. So this P16 IHC can be done. It shows a diffuse, strong block positivity. It's very important. Once you start doing IHC, you'll realize this importance of these adjectives, a strong positive and a diffuse positive of P16. This is the internet picture showing a positive P16. That means it is HPV positive. That's a very important marker, a surrogate marker for HPV. Then briefly 1 or 2 points about metaplasia and dysplasia. Squamous metaplasia is a very common occurrence in this cervix. It is replacement of columnar and endocervical epithelium by squamous epithelium. These metaplastic cells, they are more rounded, polygonal, they lack hyperchromasia. So when you see these dark cells, please do not call metaplasia. These metaplastic will not be so dark. They lack hyperchromasia. And ATP is also absent. P16, if you do, it will be negative in these. Now HPV, can it infect this metaplastic epithelium? Yes, definitely it can infect the metaplastic epithelium, squamous epithelium, columnar, any type of epithelium, and it can produce HSIL. The metaplasia could be either a mature squamous metaplasia or an immature squamous metaplasia. Mature metaplasia, it becomes a thick HSIL. Immature metaplasia, we call it a thin HSIL. Often we find this lining epithelium squamous very thin. Then still, how to tell lower 1/3, mid 1/3, upper 2/3, all those terms, because it is so thin. We can just call it a thin HSIL because the whole lining is by high-grade dysplasia. So these are some pictures of squamous metaplasia. We had another case of polyp, which showed abundant squamous metaplasia. So pale it is, squamoid cells, and the vesicular nature of the nucleus, squamoid in appearance, see extensive. Don't confuse this with dysplasia. Don't confuse this with any malignancy. It is a squamous metaplasia. And the pitfall in cytology. So imagine if a pap smear was done in this case, the HSIL in the endocervical crypts may be missed due to sampling error. If you are doing a colposcopy, again, the sampling is very important because when you take from the acetovite areas, it will show the ectocervix only. It may not go deep inside the crypt. Very important practical point. You must tell the clinician, please look carefully into the endocervical crypt and also sample from there so that we do not miss these HSIL occurring deep in the crypts. The ectocervix may be looking normal and the abnormality may be lying deep inside the crypts. We have seen several such cases. So this is a point of practical importance. I now stop this case discussion. Over to Aditya.
A warm good afternoon to everyone. I'll be presenting the case number 5 of the slide seminar for the April 2024 session. I'm Dr. C.M. Gurusadaya, the first year postgraduate from Kasturba Medical College, Manipal. So the history given was an elderly 80-year-old lady who was clinically diagnosed with conjunctival pyogenic granuloma and was undergone excision biopsy. So while studying the slides, we see a well-circumscribed lesion at a low power. And there are tall columnar cells that are projecting into cystic spaces that are seen at a higher magnification. And there are papillary projections with thinned out fibrovascular cores. And then there are a few goblet cells seen within the slides, and there are cystic spaces filled with amorphous eosinophilic material. And there are dominant oncocytes seen, which are round to columnar cells, which have fine granular deep eosinophilic cytoplasm, and they are monomorphic round to oval centrally placed nucleus, and they have a single inconspicuous nucleus. And there are a few decapitated secretions seen in focal areas. So to summarize, the given digital slide shows a well-circumscribed encapsulated lesion with cysts lined by tall columnar cells extending into lumina as papillary projections. Lining cells are columnar with abundant finely granular eosinophilic cytoplasm and central round to oval ovoid nuclei with occasional single nucleoli along with few scattered goblet cells. Some cells show decapitated secretion, and the luminal spaces are filled with amorphous eosinophilic material. So my differential diagnoses are conjunctival oncocytoma, hidradenoma papilliferum, and heterocystoma. So I'd like to evaluate each of them for the points and features which go in favor of and against each of the differentials. So for conjunctival oncocytoma, here the epidemiological factors like the elderly age and there's a female preponderance, which actually goes in favor of conjunctival oncocytoma, along with there's the histological features such as it's a well circumscribed lesion, and there are oncocytes which are columnar cells and finely granular eosinophilic cytoplasm, round nuclei, and a few cells also have a single nucleole as seen. And there's a microcystic pattern along with a few goblet cells seen. And there is a cystadenomatous papillary projection projecting into the lumen. And the negative history such as no mitotic figures were seen and no infiltrative margins, and there's no nuclear pleomorphism. So the points which go against the diagnosis of conjunctival oncocytoma are conjunctival oncocytomas are usually predominantly solid kind of lesions, and decapitated secretions are not seen in a conjunctival oncocytoma. So what we can do here to rule out that this differential is, we can further stain with some antimicrobial, antimitochondrial antibodies to know for the mitochondrial structures in the cytoplasm. And for the second differential, such as hidradenoma papilliferum, the epidemiological factors actually go in hand with the diagnosis. Like 30 to 80 years is the age group, and there is a female preponderance here as well. The histological factors such as it's a well circumscribed tumor with eosinophilic cytoplasm, has a luminal tall columnar cells. There's decapitated secretions that are seen focally. There's a complex pattern of branching focally forming papillae, and there is oxophilic metaplasia seen as well. The points which go against hidradenoma papilliferum are the myoepithelial layer, which is actually absent or which is very focally present and has been suppressed here. And my third differential, hydrocystoma, the points in favor of hydrocystoma are that it's multiloculated and it's well circumscribed, and it has an epithelial layer, but the negative point here is that it doesn't have a myoepithelial layer, since hydrocystoma comes always in the bilayer, and there are deep eosinophilic cytoplasm, there are decapitated secretions, oncocytic changes are seen, and there are focal proliferative changes as well as papillary projection. Score.
Your time is, you stick on to your timings, please.
Okay, sir. I'm just finishing.
Right, it should be within 3 minutes only. Okay.
Okay, sir.
Yeah. Go on for another few seconds. Right.
Yes, sir. Yes, sir. In the hydrocystoma, what we can further do is we can get an SMA done wherein it stains the myoepithelial layer to see whether it's present or not, or GCDFP15 or CK7, which stains the epithelial layer, the luminal layer. This goes with hidradenoma papilliferum as well. Thank you.
Okay, thank you so much. Now, yeah, we'll go to case number 5 now for discussion. I think that's a wonderful presentation, Gaurasuday. I think the differential diagnosis should be very minimal because it's a very specific lesion. Let me come to that later on. So I'll not go into the details about the history given here. Everybody's aware of it because it's a little reddish in color. When you saw the grass specimen, it was a little reddish. That's why they made a diagnosis of pyogenic granuloma. It's quite common in that area. It's conjunctival area, right? Okay. So this is cut section of tan white. Yes. Microscopically, whatever I think you have discussed, fine. But those, the secretory thoughts are very minimal. It's not seen in all the glands, but that's what we saw, right? It's a very circumscribed tumor, back-to-back arrangements of varying sized granular structures are seen. It's a dual population, predominantly you saw columnar cells having uniform round nuclei, as you said, perfectly fine. It's a deep eosinophil, that is very important, very deep eosinophil cytoplasm was there in most of the cells. Occasional goblet cells, which also you described, fine. And then, of course, you had luminal secretions. Again, I said negative points, no atypia, no mitotic activity, no necrosis, no vascular proliferation. Fine? Yes. As you can see here, as you described, most of them are, stick-like lesions. They are almost, what are these? Can anybody describe how does it look like, these things? Here, entire thing. Anybody has used Ane Patakesara? It looks like, for me, why you should always describe about what is used by the, the other authors, fine authors. We can also use our own, things what we do in Deepavali. We also use Ane Patakesara. I think it looks like, for me, like an Ane Patakesara. That's how I can, so that I can remember this very well, better than what I can see. If I can, correlate or relate it to something, what I would see. Right? Yes. Same thing what you already described. Very tall columnar. Look at this, very tall columnar cells. Absolutely no atypia. And there are some areas where you can see these very nice goblet cells also, right? Yeah. So we made a diagnosis of oncocytoma conjunctiva on the right side. Okay, let us discuss about the oncocytoma. I'll come to differential diagnosis later on. Okay. So we also had differential diagnosis of hydradenoma papilliferus as one of the differential diagnosis only, right? Now, what is oncocytoma? Is an enlargement of a cell characterized by an abundant eosinophilic granular cytoplasm. So very important. It's abundant, it's eosinophilic, it's granular cytoplasm. In view of accumulation of altered mitochondria. As you said, we can use electron microscopy to make a diagnosis really, but it's of only academic interest, not routinely, we don't do that. Some suggest it could be aging phenomena as it occurs commonly in very late, 80 years, 70 years, very aged person only we get these kinds of lesions. In some places, these lesions are triggered by an inflammation, for example, in thyroid. What do you call them as? In Hashimoto's thyroiditis, you see a lot of, Ashkenazi cells are seen, rather Fathu cells are seen. They're nothing but basically there are oncocytes. So when there's a stress to the particular gland, any of the endocrine glands, you can take it. What happens is there will be some changes happening within the particular cell. One of the changes is oncocytoma. It could be aging process, early aging process, I would say. So cutaneous sites, most commonly there are ocular, caruncle, medial eyelid, canthus, eyelid, and cheek commonly involves caruncle. Often elderly, more common in women than in men. Did I lose any of these slides? Let me just check 1 second. No, right here. Okay, fine. Thank you. So slowly growing painless mass, the lesions could be cystic or it has a bright cherry red color. Proposed origin, probably from the lacrimal gland or accessory gland. One of the important thing is to say hydradenoma is rather, I don't know whether you can get hydradenomas in the conjunctiva, I'm not sure. Because hydradenoma is usually, it comes from the sweat gland in our cells, okay? They are probably not seen in this conjunctiva, if I'm correct. And most common area for hydradenoma papilliferus is which one, Dr. Gurusiddhaya, which is the common areas you see? Can you tell me? Hello, you are there, doctor? Am I audible?
Yes, sir. Dr. Guru, please unmute yourself.
I think you have to unmute and talk, doctor.
So they're typically located in the head, neck, and limbs, sir.
Most commonly in females.
Hydradenoma papilliferum is usually seen in the vulva, sir. The vulva
Right,
region.
that's the commonest place, right? That's
Yes,
very
sir.
important. Okay.
But there are rare ectopic sites which can be seen on the face, forehead, and eyelids also, sir.
Right. Yeah. Okay, fine. That's very important. Fine. So histologically, you can see 3 architectural pattern for this. Okay, from here probably, do you get to sweat glands in the conjunctiva? Because this is a lesion from conjunctiva, right? Dr. Gurusiddhaya? I think no, right? Anyhow, let us see this. So coming to these histological patterns, we have 3 patterns. One is tubular, bas pseudo SNR, papillary and cystic, and then solid trabecular. Okay, these are the three patterns what we can see histologically. I don't have pictures, but I can find whether I can able to describe it later if I have time. But coming to the differential diagnosis, only I thought, because it's a very clear cut, again, I kept it for the junior pathologist. I'm stressing this. Is the oncocytes are very well seen and there is no doubt about the diagnosis at all. For anybody should not make a mistake of this particular thing to anything else. Only thing is you can think of whether it is oncocytosis or is it oncocytic carcinoma or is it Warthin tumors where you can get a lot of oncocytes or any other benign cystic lesions where you can see some amount of oncocytes. Okay, I think these are the areas where we need to look as a differential diagnosis. If you look at the oncocytosis, right? Oncocytosis are very rare. They are non-neoplastic. They are benign lesions. Sometimes they are found accidentally in any of the glands like salivary glands or maybe some other endocrine glands. Okay, they are microscopic lesions. They don't form any palpable lesions at all. Okay, that's important. They are usually multiple lesions in a particular gland. Suppose you take salivary gland, you're taken for something else. You may see some areas containing some oncocytes, a few areas. So that's how we look at oncocytosis. So that's one of the, when I look probably in an FNAC, which I'll come to later on when I talk about Warthin tumor. You may mistake it for squamous cell carcinoma. Okay, that's very important. When you're doing FNAC, you must be very careful. Okay, so other diagnosis would be Warthin tumor, yes, because Warthin tumor can occur anywhere beyond even apart from the parotid gland, right? The most common lesion apart from the pleomorphic adenoma is the Warthin tumor in parotid gland, and it is known to occur extra parotid glands also. That is beyond the parotid gland also it can occur. That's the importance of this Warthin tumor, and especially when you are looking at Warthin tumor, and if you are doing a FNAC, especially when it is extra parotid, near the parotid, somewhere near looking at a lymph node, it is very highly that you will make a diagnosis of metastatic carcinoma. This is very important, and we have made a mistake. So you people should not make a mistake. So whenever you see, you may be very careful that whether you are looking at whether the squamous cell carcinoma cells or you are looking at the, these kinds of cells, that is oncocytic cells. That is important because you have dysplasia, atypia, you can see spindle cells and all that in a squamous cell carcinoma, but not in a Warthin's, in a oncocytoma. That's important. And of course, it will be, because it will have lymphoid cells along with, these cells, you tend to make a diagnosis of squamous cell carcinoma metastatic. So keep in mind when you're looking at any lesions in the and around the parotid gland for an FNAC, when you get an FNAC. So basically, oncocytosis is it's a tumor-like lesion. Okay, so oncocytoma is a tumor. That's the difference. Of course, Warthin tumors will have a cyst. Usually, they're cystic in nature. They'll have 2 to 3 layers of columnar oncocytes, and the stroma will show, as I said, a lot of lymphoid cells. That's how we make a diagnosis. Okay. Oncocytic carcinoma, as I said, when you look at any of these kinds of carcinomas, in any of the eyelids or near the conjunctiva or in the oral cavity or in the lips, wherever, or in the gingiva, those places, first diagnosis you should think of whether I'm missing anything like secondaries. This is very common. Most of the secondaries, especially from the lung and from the renal, they tend to get into all these areas. And first diagnosis you must think is whether I'm looking at a metastatic carcinoma or not. That's very important. So what you should do is you should ask history from the patient, whether he has a history of earlier, whatever, whether it's a biopsy done or if they have removed some tumor, or you can ask for an ultrasound scan to look at if there's any renal lesions in the particular patient. So this is very important when you're looking at any of these small lesions, especially in an elderly female. Coming to other benign cystic lesions, other lesions, again, there will be only oncocytic changes you can see. Otherwise, there is no other differential diagnosis I can think of. Now, coming to immunohistochemistry, I think I am not much interested because most of the cytokeratins will be positive. Okay, so it's only the you can demonstrate mitochondria by using electron microscopy. That's only for academic interest. The most important, I would suggest, is that special strain like phosphotungstic acid or hematoxylin or even the PS mucin can be used to demonstrate those goblet cells. Even some of these cells, these oncocytes can have those positivity in their granules. That's very important. The other differential diagnosis somebody has said is that the granular cell myoblastoma, because they also appear very pink, they are very granular, and they also can occur in the oral cavity. So you should think of the other diagnosis, the differential diagnosis of granular cell myoblastoma. Only thing is that they are little spindle, they are oval in nature. They are more granular, little smaller than the oncocytes. Oncocytes are very big, right? But usually as seen along with muscle fibers and all that. So that also you must keep in mind. But if you can do S100 protein, because these particular cells are derived from Schwann cells, that will clinch the diagnosis. Otherwise, for oncocytoma, I don't think we should do any of the, except the special strain. The others, whatever immunochemistry I have just jotted down, not be that important. But one thing is very important is during any of the oncocytic lesion which is staying in the body for a long time, there will be some changes you can see, especially the changes like the nucleus, which are large earlier, large, and their vesicle started becoming smaller and smaller, and ultimately they become pycnotic. That's why they could be again the thesis of getting the aging of the cells could be one of the reasons why we call it as oncocytoma. So again, I'm not going to discuss much more about this because it's very classically seen. I don't have any differential diagnosis because what Dr. Siddhaya told me about the hydradema papilliferus, actually those kinds of papillary structures I'm not seen at all in this particular, and they are not pink at all. They won't be that pink what we are seeing. Those cells do not take such kind of a pink, color at all. Okay. I think we have to just say that this is basically a oncocytoma, that we made a diagnosis of oncocytoma with this available picture. And then we have ruled out oncocytosis, oncocytic carcinoma, maybe whether it Warthin's tumor, ectopic one present anywhere in the lesions in the face. Up to pharynx, we can have ectopic, in the salivary glands, where you can look at Warthin's tumor also. Okay, so, and any other discussion I would like to, be part of it. Because again, I'm telling you, I want to stress one point here is that when you see anything like this, please try to rule out in the head and neck region. Don't jump into conclusion. You have to think of first the metastatic lesion, because a lot of oncocytic tumors are present. A first presentation could be a malignant, a metastatic lesion in the head and neck region. That's important. Okay. So this is the references I have taken. And if there are any questions, I would like to take it.
There was a question that Dr. Reshma Murli, whether there were any myopithelial cells in this case.
We need to demonstrate. I am not sure whether there are any myopithelial cells are there. I'm not sure because I only found, if you look at the slides, I'll go back to the slides, right? Let me go back to the slides. Yeah. I don't think there's any, because you see, what I'm seeing here is a fibrous core here, right? And then these epithelial cells, which are pink looking, these kinds of cells, these kinds of morphology, I don't think you should mistake it for anything else at all. That's what I feel. But maybe we can demonstrate to make your diagnosis of, hydranoma papilliferus. Okay, but I don't see any papillary lesions at all, first of all. And secondly, hydranoma cells they're columnar, but they'll not have so much of, pinkish coloration, what you see here, so dark pink. So that's the difference I feel, basically. And it comes from, again, sweat gland, right? Origin. Okay. So anything, Dr. Guru Siddhaya, you want to add anything, or you're okay with this?
Yes, sir. Yes, sir. Okay, fine.
right?
Yes, sir.
So there's another query. The
Yeah,
query is whether can it be tall cell papillary carcinoma with reverse polarity?
tall cell.
Tall cell papillary carcinoma with reverse polarity.
That is with metastatic
Yeah,
lesions.
probably deposit is what they're referring to. This is from
That
Semen Pathology Trust.
see, that's what exactly. See, when you get such kind of things in your mind, when you think that it's a, probably I'm looking at a metastatic lesions. As I said earlier, the metastatic lesion, first you think any of the lesions in the oral cavity, the metastasis, either in the eyelid or in the nose, wherever. Okay, you have to talk to the doctor or the clinician whether I'm dealing with this. I think morphological, I think we can't able to make a diagnosis, if I'm correct, right? I don't think I can not add anything to say that it is a papillary carcinoma of thyroid because I'm not seeing any thyroid globules, nor I'm seeing anything morphologically fitting into the, those nucleus. Nothing is, favoring that. It could be. That's why again I'm telling you. If you think that it's probably I'm looking at a papillary carcinoma of thyroid, you can go to a thyroid scan. Okay, do thyroglobulin level, you'll come to know, or ask for the history. Maybe it's gone for So those are the difficult thing to answer on this particular morphology. But because the morphology is very very clear cut for me, I don't think I should think of anything other than the oncocytoma. Right?
All right. That's it. So no other queries. Shall we move to case number 6?
Okay. Right. Thank you.
Thank you, sir. Dr. Srividya, are you ready to share your screen? Dr. Srividya,
Yes,
please unmute yourself,
yes.
start your video, and share your screen.
So is it visible?
Please go ahead.
Yes. Good afternoon, everyone. I'm Dr. Srividya, first year pathology resident from Madras Medical College. And I'm going to present case number 6 with the history a 2-day-old female child with gluteal mass for which excision biopsy is done. And this is the overall view of the section. Here in the section, you can see a relatively circumscribed neoplasm composed of solid and variable size cystic areas. And in the solid areas, we can see the cells which are arranged in rosette and pseudo-rosette forms. The cells are ovoid to elongated with the scant cytoplasm and hyperchromatic nuclei with prominent mitotic figures or C, which are immature neuroepithelium composed of solid sheaths punctated by rosettes, which are small undifferentiated cells with foci of primitive neuroectodermic differentiation, forming neuroepithelial lamelles, which are of ectodermal in origin. And we can also see an island of immature cartilages present throughout the cell, which is of a mesodermal origin. And we can also see serous acini cells and variable sized cysts lined by mucinous epithelium, and some of them are lined by cuboidal and columnar epithelium. So the overall description is section study shows a relatively circumscribed neoplasm composed of solid and cystic areas. The solid area shows cells arranged in rosettes, pseudo-rosettes, tubules, and sheaths. The cells are ovoid to elongated with scant cytoplasm, hyperchromatic nuclei, and prominent mitotic figures are seen, which is a neuroectoderm. And also seen on island of immature cartilage, which are of mesodermal origin, and surrounding stroma shows loose mesenchymal components and congested blood vessels are also seen. The cystic areas composed of varying sizes cysts lined by cuboidal, columnar, ciliated columnar, mucinous epithelium, which is of endodermal origin. So overall, we got the structures from all the 3 germ layers. So I'll conclude my diagnosis as extragonadal immature teratoma with more than 50% of immature elements. My differential diagnosis will be a mature cystic teratoma. In mature cystic teratoma, we can only see the mature endodermal and mesodermal components like a mature cartilage and sebaceous glands and fats. No neuroectodermal elements will be present, and we can also consider mixed germ cell tumor for which you need to see the presence of a yolk sac elements, which is Schindler dual bodies, must be seen in the studies. So as it is not seen, I conclude my diagnosis as an extragonadal immature teratoma with more than 50% of immature elements. And we can also differentiate using IHCs, for which you need to put SOLL4 and SOX2, which is expressed in immature neuroepithelium and which will be absent in well-differentiated teratomas. And 4 can also be used, which is expressed in high-grade immature teratomas. Thank you.
Yeah. So, Dr. Srividya from Mysore Madras Medical College, I think that was a neat presentation, and you have covered most of the points which I had intended to explain. So you made my job much easy. Thank you. And when we see the history itself, a 2-day female baby with a large gluteal mass, immediately in your mind you should come the diagnosis of a teratoma occurring in the sacrococcygeal region. It's not that common, 1 in 30,000 or 1 in 40,000 births, but still that history you can think of that. And this mass was very huge, 16 centimeters, and it was very well encapsulated. I'm sorry I don't have a picture of this mass. It was almost more than a year old and I lost the photograph. And it was solid and cystic. And when we saw the microscopy, I think Vidya has clearly told what is striking is the neuroepithelium, because most of the areas we are seeing the neuroepithelium, and that is the one which is very striking to us, this picture. Of course, there are other elements of ectoderm, endoderm, mesoderm, but this neuroepithelium is striking. So we have to keep in mind the grade. How do we grade these kind of tumors? And there were some areas where the primitive mesenchyme was seen, some kind of tubules were seen, some kind of yolk sac tumor-like areas were seen. Yolk sac tumor, how do we describe? It's a very loose, reticulated network, like, very loose it is. And that kind of area, yolk sac tumor-like areas were also seen. Mature glial tissue was seen here. See, very typical mature glia. See in hyper, it's almost a mature, resembling the adult glia. And immature mesenchyme, the yolk sac tumor-like areas. And after a lot of searching, I found one small strip of squamous epithelium like this. That was also kind of immature. It was not showing the maturation into various layers. And then we saw the columnar line, the glands. And then we saw this kind of columnar glands. We saw some squamoid areas. And here you can see both the squamous epithelium. See here, somewhat like a transitional epithelium it looks, and some kind of a columnar epithelium. And this is the cartilage. I think Vidya has shown this cartilage also, and some seromucinous glands. All these we have to search for it. And then calcification here, and some kind of an abortive hair follicle-like areas, calcification areas. All these we saw, and that's the summary of this case. Now, we know we are dealing with some kind of a teratoma, and we saw all the 3 layers. But what is the term to give this the correct term? We received an overwhelming 153 responses from the postgraduates and consultants. It was indeed overwhelming, and we had to sit and go through all of them. The teratoma with yolk sac tumor, immature teratoma, that was the highest number of responses. I'm very happy that most of you have given almost the correct diagnosis of the immature teratoma, dermoid cyst, mixed germ cell tumor, that is teratoma with yolk sac, and a sacrococcygeal teratoma. So our final diagnosis for case 4, immature sacrococcygeal teratoma, high grade. So we have given the grade also for this kind of teratomas. IHC, we have not done the IHC for this case, but as Vidya already mentioned, we could do a SAL4, SOX2, glypican-3 to demonstrate neuroectoderm, and AFP to demonstrate the yolk sac tumor-like areas. So coming to the discussion part of the case, these teratomas, they are basically from the primordial germ cells. So in the yolk sac, they start proliferating and they start migrating towards the genital ridges, that is the gonads, and they pass through this midgut and during the 5th week of gestation. The abnormal migration of these germ cells in the intrauterine period in the 5th week, it can lead to these germ cell tumors in the extragonadal lesions. So we have teratomas in the gonadal and extragonadal, and that point is very important to remember. Extragonadal, the location is usually midline, either in the retroperitoneum or in the mediastinum or anywhere in the midline. These are the common locations for extragonadal locations. And histologically, you know that there are all the three layers. The maturation is very variable. In a benign teratoma, it is very, very mature tissue resembling the adult mature tissue. Whereas if it resembles a fetal tissue, it is an immature teratoma. And they are organized also very haphazardly, disorganizedly. So that is the importance where we find sometimes difficulty in making a diagnosis. And immature, as she told, the neuroectoderm can be a fetal neural tissue or resembling the mature adult glial tissue. When we call benign teratoma, you could get neuroectoderm, but it will be a mature glia. For all those, we do not use the word immature teratoma just because there is a neuroectoderm. It should be an immature neuroectoderm to call it immature. Just mere presence of a mature neuroectoderm does not qualify to call it as an immature teratoma. Please note down this point. And you'll also find other fetal tissues like primitive mesenchyme, primitive cartilage, etc. Sampling of the tumor. This is the most important take-home message in this case. You have to sample every 1 centimeter. You should not miss any immature neural elements. You should not miss any occult foci of malignancy. So we grade 1, grade 2, grade 3, depending upon the immature region per slide. 1 low power field immature region in 1 slide, grade 1. Immature tissue in less than 4 low power field per slide, grade 2. Immature tissue more than 4 low power field per slide is grade 3. In our case, it was grade 3, which is the high grade. That's how we have termed this case. And the prognosis depends upon the malignant potential of these components and depends upon the histological components. And also remember the gonadal teratoma, the terminology. In case of male gonadal teratoma occurring in the testis, we use the term prepubertal teratoma, post-pubertal teratoma. Whereas in the females, we call it the benign cystic teratoma or the benign teratomas, the immature teratoma and the malignant teratoma. And in the extragonadal sites, we usually use the term graded based on grade 1, 2, 3. And generally we don't write mixed teratoma, yolk sac tumor because all these are immature fetal tissue. It looks malignant only. We are not very sure about its behavior, about its malignant potential. Whereas if it is occurring in the adults in the ovaries, we'll call them as mixed teratoma plus yolk sac tumor because we know that they do behave in a malignant fashion. So this terminology of a gonadal and extragonadal teratoma is something we can learn in this case. So with that, I end my discussion on case number 2. Over to the next case.
Hello, good afternoon everyone. Myself Dr. Ajit Kumar Gowda from KVG Medical College, Sulya. We got a case of case number 7 with slide number 5. Starting with the case. This is a case history with a patient of 51-year-old male with a history of cervical lymphadenopathy with a multiple enlarged level 2 and level 3 lymph nodes. And these are the sections what we received. This is under a scanner, in a scanner view, showing a complete effacement of a lymph node architecture, and there is no capsule. And under a 20x, you can see a diffuse proliferation of a small lymphocytes with a reactive small lymphocytes that mixed with some histiocytes. Under a 40x, you can see a few scattered Reed-Sternberg cells having a bilobated nucleus showing a prominent eosinophilic nucleus and ample amount of amphiphilic cytoplasm. And in other sections, other focus, you can see some occasional mummified cells are also seen, and there is no evidence of other polymorphic population of eosinophils or eosinophils. And other focuses, you can see a proliferation of high endothelial venules noted here. You can see to differentiate between high endothelial venules and normal endothelial venules. In high endothelial venules, normally it will be endothelium will be flat, whereas in high endothelial venules, the endothelium will be tall and plump-like, and basal lamina will be thick in case of high endothelial venules. And you can see occasional mitosis here. Based on these pictures or these sections, we came to the with a summary of absence of capsule and complete effacement of lymph node architecture is present, and cortex and medulla is replaced by a mature lymphoid cell, thus of a small lymphocytes, and there are occasional scattered of presence of atypical Reed-Sternberg like cells, and you can see a proliferation of eye endothelial venules seen in the pictures. And with this, we came to the differential diagnosis of lymphocyte-rich classical Hodgkin's lymphoma and lymphocyte-predominant Hodgkin's lymphoma and angioimmunoblastic T-cell lymphoma. To roll out this, I made a simple tabular table. What is like a lymphocyte-rich classic Hodgkin's lymphoma? There will be in all three differential diagrams, there will be a partial or diffuse replacement of a lymph node architecture, whereas in lymphocyte-rich classical Hodgkin's lymphoma, you'll be seeing a few Reed-Sternberg cells and Hodgkin cells within a mass of lymphocytes, whereas in lymphocyte, we'll be seeing more commonly a lymphocyte predominant cells. Those are popcorn cells or mummified cells. And in a lymphocyte predominant, there will be a histiocytes with it may be epithelioid form or a small granulomas. And it usually classical lymphocyte rich involves a peripheral lymph nodes, whereas a lymphocyte predominant involves most commonly a cervical and axillary lymph nodes. And coming to the angioimmunoblastic T cell lymphoma, these are the neoplastic T cells with clear or pale cytoplasm. Mainly will be observing a proliferation of arborizing eye endothelial venules and proliferation of a follicular dendritic cells. And you will be seeing a presence of small reactive lymphocytes, plasma cells, eosinophils, and histiocytes, whereas these features will be minimal or absent in case of lymphocyte rich and lymphocyte predominant. And to confirm this, we'll go through a IHC for a lymphocyte-rich classical Hodgkin's lymphoma. We'll go for a positive markers for a CD15 and CD30, whereas negative with a CD45 and CD20. For a nodular lymphocyte-predominant Hodgkin's lymphoma, positive markers are CD20, 22, PAX5, OCT2, and CD45, whereas negative markers are CD15 and CD30. For angioimmunoblastic T cell lymphoma, immunohistochemistry markers are CD2, CD3, CD5, BCL6 will be positive, along with the CX, CL30 positive. Based on these features, we came with a diagnosis of a lymphocyte-rich classical Hodgkin's lymphoma. These are my references. Thank you.
Yeah. So, Dr. Ajit, it was a very good presentation, and you have covered almost all the points that I had prepared. So we will start with the clinical details. 51-year male patient. He presented with low-grade fever and loss of weight. There were palpable cervical lymph nodes. Level 2 and level 3 were also involved. So on gross finding, multiple nodular bits were received. The largest was measuring 3.5 centimeters. In cut section, they were firm, tan white with rubbery consistency. So I would like to stress upon this point, the rubbery consistency. So that will give you an idea. So microscopy, you can see it's a scanner view. There is it's an enlarged lymph node with complete effacement of architecture, with kind of vague, diffuse, and focal nodular infiltration of inflammatory cells that are mainly composed of, like you can see in this picture, there are small lymphocytes. You are seeing few histiocytic cells and occasional cells. See, like here you can see epithelioid kind of cells. Okay. This is a cell like Dr. Ajit already pointed out, a mummified kind of a cell. This is another aggregates of histiocytic cells. And coming to this one, it's a mononuclear classic Reed-Sternberg cells, mononuclear type. Binuclear form. And there were few, occasional microgranulomas, epithelioid microgranulomas were also there. So to summarize it all, it was a lymph node with completely effaced architecture. There is diffuse and vague nodular pattern is present, predominantly small lymphocytes, histiocytes, and epithelioid cells forming microgranulomas. Then the neoplastic cells were large, atypical, mononuclear forms were there, binuclear vesicular nuclei, and prominent nuclei. They are like pathognomonic for HRS cells. And occasional lacunar cells were also seen. Then the most important is the negative findings. There were no eosinophils, there are no neutrophils. So that gives you an idea, even if it is an Hodgkin's lymphoma, where in what subtype you expect eosinophils and neutrophils, and the what subtypes you don't see eosinophils. Then there is no sclerosis, there is no perinodal extension. Actually, the slide that we have got it for digitized, there is no proper capsule that you can see, but there were other slides in which there was a proper capsule and there was no perinodal extension in that, and there is no vascular proliferation, not increased vascular proliferation. Basically, that's what I mean, and there is no necrosis. So we gave an impression of lymphoproliferative disorder favoring Hodgkin's lymphoma. The DDs for us were lymphocyte-rich classic Hodgkin's lymphoma versus a nodular lymphocytic predominant Hodgkin's lymphoma. And also we had another DD, that is angioimmunoblastic T-cell lymphoma, a type of non-Hodgkin's lymphoma. So then we did a very extensive panel of immunohistochemistry. The neoplastic cells, they were positive for CD45. Sorry, they were negative for CD45, but there was diffuse positive in surrounding background cells. And these neoplastic cells were positive for CD15. CD30, there was nice membranous Golgi dot positive. PAX5, it was weak positive in RS cells. CD79A, it was negative. CD20, that was also weak positive in RS cells. Also in those large cells and B cell population. MUM1 was positive, and we had done Eber by Ish, which was positive diffuse nuclear. And the background cells were positive for CD3, but the neoplastic cells were negative for CD3, and the neoplastic cells were negative for CD10 as well. BCL6, BCL2, ALK1 was negative, cyclin D1 was negative. CD23 also we had done, and only remnant, that too in the periphery, few remnant scattered dendritic cell network that had taken up highlighted. CD5 was negative, and we had done EMA, which was non-specific. It was basically negative. So I guess with this extensive IHC profile, the most of the differentials are ruled out. Like these three are enough. Like CD45 is negative, CD15 positivity, CD30 positive. Now you know it's a Hodgkin's lymphoma. Okay. Then PAX5 and CD20 are mild positive, weak positive. The NLPHL, usually CD45 will be positive, and CD15 and CD30, usually CD15 should be negative. CD30 can be seen in few cases of NLPHL. And your these cells are negative, the large cells are negative for CD3, BCL6 and CD10. That rules out your angioimmunoblastic T-cell lymphoma and also your ALCL. And this EMA, these large cells were negative for EMA. That usually rules out any metastatic carcinoma, because when I went through the different diagnosis that was given, so there were a few people who had mentioned it as metastatic carcinoma. So this negative EMA should answer that. So EMA is negative, that rules out any metastatic carcinomas. And also I had seen there was few people had given it as histiocytic sarcoma. So usually histiocytoid cells will be positive for CD45 as well, but it was negative. To summarize it, there is a peripheral lymphadenopathy, a diffuse pattern with typical RS cells in the background of small lymphocytes and epithelioid histiocytes. IHC, they were positive for CD30, CD15 and MUM1, weak positive for PAX5 and CD20. Eberish is positive, negative for CD45, BCL6 and EMA. CD23 highlights remnant follicular network. So diagnosis was given as lymphocyte-rich classic Hodgkin's lymphoma. Coming to just a little bit of discussion part. Anyways, you will get the whole detailed part in WHO textbooks. It's all there. So approximately they constitute about 5% of all classic Hodgkin's lymphomas. Usually you will see peripheral lymphadenopathy. That's a typical presentation. Mediastinal and bulky diseases are usually uncommon. Usually the patient will present with stage 1 or 2 disease. And B symptoms like, like I said, evening rise of temperature, and even the fever, continuous low-grade fever, and hepatomegaly, splenomegaly, they're all very rare. These kind of symptoms are rare in cases. And on microscopy, usually you see two growth patterns. Nodular is the most commonest, and diffuse is it's uncommon. So it can be easily confused with NLPHL. So it's very important you differentiate the classic Hodgkin's lymphomas from NLPHL. That too, the lymphocyte-rich lymphocyte-rich variant, because it definitely decides the treatment modality and also the prognosis. So demonstration of immunophenotype typical of classic HR cells, RS cells, is very essential. And even the prognosis wise, with modern risk adjusted treatment, that is that CHOP regimen along with radiotherapy, oral and progression free survival rates are slightly better than the other types of CHL, and it is similar to those of NLPHL, except that the relapses are more common in NLPHL than LRCHL. This is a tabular column that I have taken from WHO. So they give the panel of markers that you can, differentiate, use them to differentiate from nodular lymphocyte predominant. And there is that new type that is coming up right now, that is T cell and histiocyte-like, histiocyte-like lymphoma, then DLBCL, ALCL, ALK positive and ALK negative. So, thank you. So, any doubts? It's all immunohistochemistry. So, I think I have cleared out most of the differentials. And I'm so sorry I could not share the immunohistochemistry pictures because the patient has collected the slides and we could not take it.
Thank you, Dr. Kruti. We shall move on to the next case.
Okay.
Dr. Jagrati.
Yes, sir.
Please share your screen and.
Yes, sir. Sir, am I audible?
Physical changes.
Done, sir. I'll go down.
Well,
Thank you.
very nicely done. Great.
So can I start, sir?
Yes, please go ahead.
Go ahead.
So very good afternoon to one and everyone. I am Dr. Jagrati Singh, third year postgraduate from the Department of Pathology, KCIAPM Medical Academy, Mangalore. My slide number allotted to me is 8, slide 9A. So clinical details: a 9-month male, right kidney with history of Wilms tumor, left kidney, partial nephrectomy done for renal mass. So in the scanner view, as we can see that there's a partially encapsulated tumor, and we see that it is in a perilobar region. And in the lower part, we can see that there's a partial encapsulated lesion along with the adjacent normal renal tissue. This is the adjoining renal tissue, normal renal tissue with glomeruli and tubules. And we can see that the tumor, it is arranged in lobules showing papillary, alveolar and tubular pattern. So we can see the papillary, alveolar, and here we can see multiple psammomatous bodies, multiple psammoma bodies, and we have branching tubules and papillary architecture with few cystic secondary degenerative changes and psammoma bodies. These are the neoplastic cells, which are small round blue cells with scant cytoplasm and Hobnaili. We can see some secondary degenerative changes and psammoma bodies. These are the interlacing stroma with smooth muscle cells. So summarizing, we have seen a partially encapsulated tumor in the perilobar region, which is having papillary, alveolar and minor tubular pattern, lined by small round blue cells and scant cytoplasm with Hobnaili, with plenty of psammoma bodies and moderate edematous stroma. So coming to the first DD, we'll take it because the patient is having a history of Wilms tumor, we will take it as epithelial predominant nephroblastoma. The supporting diagnosis is age, and it is a capsulated lesion, lobulated with stromal separation, and epithelial cells are predominant. Points against it is that it is lacking blastomal cells and elongated nuclei and small nucleoli. My second DD is a hypoplastic perilobar nephrogenic rests, as it is having history of nephroblastoma. See, it is seen in up to 40% of patients with Wilms tumor and approximately 1% of neonates with papillary and tubular architecture and scant stroma. My points against are the size, partial encapsulation. Usually, the hypoplastic perilobar nephrogenic rests are usually multifocal, and there is no blastomal component C. My third TD is metanephric adenoma, which is seen in younger age group, which is well circumscribed, elongated branching tubules with areas of papillary architecture. Neoplastic cells are small and basophilic with almost no cytoplasm, bland nuclear features, edematous stroma, and some of bodies are common. My points against are it is more common in adults. Females are more commonly affected in males. Here, our patient is a male, and back-to-back tubules are not seen. My fourth DD is alveolar rhabdomyosarcoma. As we are seeing a very predominant alveolar pattern, small to medium-sized round cells. And points against is that we also have a papillary and a tubular pattern, which is not seen. My last DD is low-grade papillary renal cell carcinoma, which shows a distinct interface, as in this, between tumor and uninvolved renal parenchyma. Papillary pattern with few tubules and dystrophic calcification is seen. My points against, because it lacks a vesicular chromatin and abundant cytoplasm. So we need a multidisciplinary approach and come to the final diagnosis. Thank you.
Thank you, Dr. Jagriti. Excellent presentation, and you've done all the discussion which I was supposed to do. So your differentials are bang on. I would maybe not put so many differentials in this case, but of course, you're free to go ahead with that many. But let us see what we thought of. I'll jump straight to my cases. And is my screen visible now?
Not yet, sir.
It's not yet. It's not. Just give me a moment. Right. Yeah, case number 8. So going by history, there was a history of a previous nephrectomy done for Wilms tumor elsewhere, which happened 3 months ago. And this was on the right side. And now we've got a left partial nephrectomy done for the renal mass. And this mass measured 1 by 0.8 centimeter. So it was a small mass, but definitely it was grossly visible, which is an important point, as we'll see later on. Microscopy, I will not go into it. Dr. Jagrati has already done more than enough of it. Let me jump straight to the responses that we received. So we've got several responses. Among the top, we have Wilms tumor, metanephric adenoma, papillary RCC, papillary adenoma, and nephrogenic rests. And as Dr. Jagrati already mentioned, nephrogenic rests is also a differential. But I would go against nephrogenic rests because they're very small, not grossly visible usually, and generally are, generally do not have any capsule and tend to merge with the surrounding normal renal parenchyma, which we did not see here. Papillary adenoma or papillary tubular adenoma is a relatively good differential diagnosis. It is limited by the fact that by definition it should be less than 1.5 centimeters. Ours is 1 centimeter, so it could still be a papillary adenoma. Again, papillary adenomas are not encapsulated. Ours was encapsulated. And so these two, I think, I will remove from the differentials at this stage, and we'll retain the 3 other differentials: Wilms tumor or nephroblastoma, epithelial predominant, metanephric adenoma, and papillary RCC. So these we'll retain. So we also went through this kind of differentials when we encountered this case, and obviously we had to look at the IHC. Dr. Jagrati, one differential that I would disagree with yours is the alveolar rhabdomyosarcoma.
Okay.
Right? I mean, yes, they do have an alveolar pattern, but I don't think the cellular morphology has any features that kind of suggest rhabdomyosarcoma. That's why I would not entertain that differential, but I'll keep the other differentials intact. So we went ahead with the IHC, and any IHCs would you suggest, Dr. Jagrati, at this point?
So PAC-C, WT1,
Good, very good, very good.
the EMA.
Okay, okay, fine. Fine. So we went ahead and we did this panel of markers, and in over here the markers are selected by our experts, Dr. Kriti and Dr. Varsha. They pick up the markers which needs to be done, and it's an important thing how you choose your markers. Okay, so that you don't get. If you do a lot of markers, if you do the wrong kind of markers, you end up having difficulty in interpretation. So the choice of markers is also very important. So for us, we did WT1, which is strong and diffusely positive. And what does that rule out? That rules out papillary RCC. And CK7 was patchy positive, EMA was seen in scattered cells, PAX8 focal. All these, with the presence of a diffuse WT1 positive, rules out papillary RCC. But we are left with the other two differentials, that is a Wilms tumor and the that is the epithelial predominant nephroblastoma and metanephric adenoma. If you look at the literature, you'll find that metanephric adenomas are described or is expected to have a diffuse CD57 positivity. However, in our case, we found it patchy positive. So immunohistochemistry, again, we are left with the same dilemma. Are we dealing with a metanephric adenoma, or are we dealing with epithelial predominant nephroblastoma? So immunohistochemistry was of limited utility, but it did help us in completely ruling out a papillary RCC. So to summarize our lesion, which is a relatively well encapsulated tumor with predominantly tubular papillary pattern, very small cells, numerous among bodies. Importantly, no mitotic activity was observed. I'm sure most of you did not encounter any mitosis in this lesion. No necrosis of blastomal or stromal components were also present. So going by the combination of this cytomorphology and the immunohistochemistry, the preference that we gave among the two differentials, is it an epithelial predominant embryon nephroblastoma or is it a metanephric adenoma? So we gave predominance to the absence of mitosis, the cellular morphology, and the kind of patchy CD57 positivity. CD57 is expected to be negative in nephroblastoma. So going by these factors, though we did have a few which went against our diagnosis, like the encapsulation, and the age, of course. Going by the factors that immunohistochemistry played a role and the microscopic routine HND, our diagnosis was ultimately metanephric adenoma. Note that this would mean that this is a case of metachronous nephroblastoma and a metanephric adenoma, which is a very, very unusual lesion. So metanephric adenomas are generally in the older age group, and the youngest mentioned in WHO is 5 years, and ours is not even close to that. So that is against a diagnosis of metanephric adenoma. They generally lack pseudocapsules, unlike nephroblastoma. We had a pseudocapsule. So these are a couple of points against our diagnosis. But the all other features, the embryonal primitive epithelial cells, the absence of mitotic activity, the typical tubular-papillary architecture, and the sum of bodies are all in favor of metanephric adenoma. So we continue to decide on metanephric adenoma in this case. Metanephric adenomas show BRAF V600E mutations in as much as 90% of cases. We did not do this mutation, but it's something which you can try if you have a differential like how we have. It helps in making a differential diagnosis when you have an issue with epithelial predominant Wilms tumor. The other differentials that we already discussed earlier is papillary RCC and epithelial predominant nephroblastoma. These are the two main. IHC is helpful in differentiating these two elements, as we've already seen. So I will not again repeat this aspect. There are very few case reports, literally isolated case reports of such metachronous lesions or synchronous lesions involving nephroblastoma and metanephric adenoma described in literature. I could find just 3 such references. So these are very, very extremely rare lesions. And for looking at the histologic and immunophenotypic comparison, I would suggest that you read this article. This is not available free, but it's there in the American Journal of Surgical Pathology, which gives you a detailed look at how you can differentiate these entities based on immunohistochemistry. And WHO Blue Book is an excellent reference. It gives you a lot on metanephric tumors, metanephric adenoma, metanephric stromal tumor, metanephric adenofibroma. All these are very well described. So we conclude this session, this case by telling you that sometimes the IHC may not always be completely helpful, and we may have to go back to the histomorphology or HND sections and combine both these features to arrive at a diagnosis. So this we thought is a metanephric adenoma. Any questions? Please feel free to ask me in the chat box. If you have any queries later on, you can call me up or message me on this email ID. Thank you so much. Jagrati, thank you so much, Dr. Jagrati, for your presentation. I have no further queries to ask you in this particular case. Any questions from the audience? Please feel free to put up in the chat.
Nothing as of now, sir. We should move to case number 9, Dr. Anaga. So please stop sharing the screen so that Anaga can take it. No.
Sir, is it visible?
Yes, Anaga, put it on slideshow mode and go ahead.
Good afternoon. Myself, Dr. Anaka is from Karnataka Institute of Medical Sciences, Hubli. The history is that of a 35-year-old female with query CA ovary stromal tumor. Patient has hirsutism and hyperandrogenism. This is the lower view of the entire section. Here you can see hypercellular areas, eosinophilic areas, and hypocellular areas. On focusing on the hypercellular areas, you can see cells are arranged in tubules separated by fibrous stroma. Here you can see plump spindle cells. This is the hyper view. Here also you can see cells are in tubules and also in coats. Again, you can see round cells with the vacuolated cytoplasm and also surrounded by plump spindle cells. This is seen from a different area. On focusing on the lower area, you can see dark cells arranged in acidy and also in coats. Here also you can see cells are arranged in coats. There are round cells with eosinophilic cytoplasm. These could be Leydig cells, luteinized cells, or malignant epithelial cell. Some areas you can see signet cells, which are arranged in singles and also in clusters. These are eosinophilic areas having luteinized stromal cells and eosinophilic cells having some pigment in between. These are vacuolated cells with pigment. This is the area showing hypercellular area and luteinized stroma. This is from the periphery of the section showing here. You can see spindle cells are arranged in storiform pattern. To summarize, section studied shows structure of ovary. Lower view shows densely cellular areas and hypocellular edematous stroma. Within the cellular areas, tumor cells are arranged in tubules and coats separated by plump spindle cells. These cells have increased NC ratio with coarse chromatin and irregular nuclear membrane and moderately eosinophilic to vacuolated and clear cytoplasm. Few areas of eosinophilic showing luteinized stromal cells admixed with large cells having round vesicular nucleus and abundant eosinophilic cytoplasm. Few of these cells show vacuolated cytoplasm with pigment. Scattered signet ring cells in clusters and singles are seen in stroma. At some places, stromal spindle cells are arranged in fascicles. Also see congested and sclerosed blood vessels. So with the history and microscopy, my most likely diagnosis would be a moderately differentiated Sertoli-Leydig cell tumor and a Krukenberg tumor. Here, we need to rule out signet ring stromal tumor and sclerosing stromal tumor as signet ring cells are present. So in both these cases, a tubular or coat-like pattern will be absent and they are non-functioning tumors. So my first DD would be a Sertoli-Leydig cell tumor where average age of presentation is 25 years and half of patients will show signs of visualization. So this case is more resembling a moderately differentiated Sertoli Leydig cell tumor showing alternating hypo and hypocellular areas, Sertoli cells in coats without open lumen formation and less number of Leydig cells. As signature cells are present, my second DD would be a Krukenberg tumor, where metastatic carcinomas with component of signature cells comprising at least 10% of the tumor will be present. Patient will present with non-specific symptoms, but virilization during pregnancy can be seen due to stromal utilization. A variant of Krukenberg tumor known as a tubular variant, hollow or solid tubular glands may appear separately like from the focal component of signature lining duct. So my points favoring Sertoli Leydig cell tumor would be age and the signs of virilization, alternating hypo and hypocellular areas, compressed tubules and coats, which could be Sertoli cells, clusters of cells with abundant eosinophilic cytoplasm, which could be Leydig cells, and points favoring Krukenberg tumor would be young age and again signs of virilization, which could be due to the stromal reaction, presence of signature cells and cells with dense eosinophilic and clear cytoplasm in coats and tubules. So my final diagnosis would be either a moderately differentiated Sertoli Leydig cell tumor or a Krukenberg tumor. Most of the Sertoli Leydig cell tumor express inhibin and calretinin, and Krukenberg tumor based on the origin of the tumor may express CK7, CK20 and CDX2.
Yeah. So, Dr. Anagha from Hubli, you have discussed most of the points. Am I audible?
Yes, ma'am.
Yes, ma'am.
Yeah, you have discussed most of the points, including the differentials, IHC, and everything, and you have made my job not just easy. I wish I would have spent less time preparing for this case. And what I want to tell you is your diagnosis, your differential diagnosis, both are right. So let us see how both can be right. How can Sertoli Leydig and a Krukenberg both? How can it be right? Okay, so that mystery we will unravel now. In this case, what happened is, when the clinician sent us the case itself, they told us it's a 35-year-old lady. She has hirsutism. She has hyperandrogenism. And we have done a scan, and there are bilateral ovarian masses. And our diagnosis is a carcinoma of the ovary or a stromal tumor of the ovary. So it was completely a biased clinical history, where when we were very sure, yes, it is fitting into a stromal tumor of the ovary. And then the tumor came, and it was a left ovary. It was 8 centimeters with intact capsule, and the contour was maintained. Why I'm emphasizing, look at this contour, the normal ovarian contour, no? Though it is enlarged, it has maintained that. This again favors a Krukenberg. Classically, Krukenbergs will be bilateral and the contour will be maintained. But this was biased, and we were thinking, yes, it is a stromal tumor. We have such beautiful visualization symptoms. We have the change in voice. We have the hirsutism, everything. But this tumor, this point is to be noted, enlarged ovary with retained contours. And it was very solid with somewhat glistening appearance, small cystic, small areas of hemorrhage. And the microscopy, I will not emphasize, it was so cellular, full of small tubules and this stroma. And we were thinking, which tumor looks like this? It cannot be a well-differentiated Sertoli Leydig, because you would have seen very beautiful, well-formed tubules. Here, tubules were very small, not so conspicuous. The stroma was very, the spindle cells was very, very dark and very angry looking, and it was more conspicuous. So mitotic activity also was seen. So with all this in mind, we thought, okay, what are we dealing with? And the response that we got from the students and the consultants, the entire list of stromal tumors, fibrothecoma, granulosa, sex-cord stromal, Leydig, unclassified. Of course, Krukenberg, we got several responses, and that's a good note. Gonadoblastoma, luteinized thecoma, polydifferentiated Sertoli Leydig, gynandroblastoma, metastatic melanoma, steroid cell tumor. So this was some of the spectrum of diagnosis we received. Our first impression was Sertoli Leydig cell tumor, moderately differentiated. Why moderately? Because in well differentiated, I told you, morphology is quite clear cut. Here the tubules were not so classical, so we called it moderately differentiated, and we suggested immunohistochemistry. I'm not calling this the final diagnosis. This was our initial diagnosis. Then we ask for IHC. Meanwhile, the clinician, the surgeon calls up and tells, after your report, we have done a PET scan and we saw the report saying there were multiple deposits over both the ovaries, appendix, omentum, subdiaphragmatic, everywhere there were deposits. And the young age of the patient, she's hardly 34. And we wanted to conserve the ovary. We wanted to do a staging laparotomy and plan the final surgery because it was extensive spread. So we want a working diagnosis. That was what the surgeon said, and he has sent us only the left ovary, which was removed first. In the second surgery, he sent us the right ovary, appendix, uterus, omentum, right diaphragmatic stripping, right and left external iliac, internal iliac, obturator, colonic deposits, small bubble deposits, para-aortic nodes, everything was removed, and we received some 10-15 containers. And lo and behold, when we saw the appendix, it was looking normal sized appendix. Okay, there was no gross tumor in the appendix, but it was showing this picture in the appendix. And look at the small tubules, and look at the desmoplastic stromum, look at this glandular pattern, the LVI, the lymphovascular invasion into the adipose tissue. Here you can see some lymphoid follicles and this kind of a glandular neoplasm, and look at this emboli going into the vessels. Lot of tumor emboli we could see here, lymphatic, vascular, and higher magnification. Look at these atypical cells lining this kind of a glandular structure. And this, we thought, yeah, this looks like an adenocarcinoma. And the same picture we saw in all the rest of the containers. Those deposits and the other ovary, and then these lymph nodes, everywhere we saw the same deposits. We then thought we will review the left ovarian tumors. After seeing the adenocarcinoma on the right side and the appendix, we reviewed the left ovarian tumor, and then we said, no, we will do IHC on not just the appendix, on the left ovarian mass. On both, we will do the IHC. So this is one point of good practice which you need to remember, that you can do IHC on more than one organ or one tissue in a given specimen when the morphology looks little varied. So how do we approach the IHC now in this case? A pan-CK to demonstrate the epithelial origin, WT1 for a serous carcinoma. Behavior-wise, serous carcinomas behave like this. They have extensive spread all over the pelvis and the abdomen. So we thought we will put up WT1 for a serous carcinoma. CK7, CK20, gold standard to know CK7 positive, 20 minus, or this minus, that plus, and then we have the algorithm to say which is the origin, breast, lung, GI, etc. CEA for colorectal carcinomas and also some gastric type of adenocarcinomas. CDX2, which is a specific marker for GI origin. I think Anaga has mentioned CDX2. And inhibin calretinine, of course, for a very initial diagnosis of granulosa cell tumor or Sartori Leydig cell tumor, any of the Streck-Scott stromal tumors, and the Ki67. So this is how we approach the IHC, and these are the IHC images. A pan-CK, first I'll tell you the ovarian IHC. Pan-CK very nicely, strongly positive. WT1 was not positive. CK7 positive, CK20 positive, and NSE and CD56 was very weak. That those are the neuroendocrine markers. The inhibin calretinine was showing some kind of a positivity only in the spindly cells, in the spindle cell component, and not on those tubules, not on those glandular structures. What about the appendix? We did the IHC on the appendix also. It showed CK7 diffuse strong positive, CK20 was focal. You can see just one area here positive. CEA was very strong positive, CDX2 was weak, and inhibin, synaptochromo, all were negative. So that was a summary of the ovarian tumor IHC and appendix. So important to note, pan-CK positive, CK7, CK20 positive, CEA, CDX2 also positive. The rest were negative. KI was around 20%. So the final diagnosis that we gave out in this case was an adenocarcinoma of GI tract primary with metastasis to bilateral ovaries, that is the Krukenberg tumor. Metastatic deposits seen in appendix, right ovary, omentum, right diaphragmatic stripping, colonic mesenteric, and small bowel mesenteric. 4 out of 12 lymph node deposits positive. And another point of good practice, we went back and we amended the report of the left ovary and released our amended report. So the discussion of this case is a luteinized. So why this case had hirsutism and virilization? It is because not just in stromal tumors, even in Krukenberg tumors, the stroma can get irritated. The stroma can produce some kind of a functional activity, a luteinized stroma, and they can produce the androgenic hormones. The initial left ovarian tumor had a marked stromal reaction, desmoplasia, infiltrative tumor, and this misled us to diagnosing a Sartori Leydig cell tumor. And we got misled, and we interpreted this stromal reaction to the adenocarcinoma deposits as maybe a Sartori Leydig cell tumor. Plus, I told you initially itself, the clinician had misled us, had biased us, not misled, had biased us into making this diagnosis. So it is always better to give an amended report, especially after performing immunohistochemistry. So that's the take-home message in this case, to release amended reports, to always review. If the clinician asks you, kindly review. You have to be open-minded, and review your report, what you have given, and not think that you're always right. So there are so many things to consider. Always better to take the second chance, review the report, and give an amended report. If it is still the same, no harm. You can say we have reviewed and the report continues to remain the same, no amendment. We can release that kind of a report also. No harm in that. So we end the discussion on this case, and I thank you for your patient listening.
Okay. So myself, Dr. Nusrat Jahan, third year postgraduate from WIMS Ballari. So the case given to us was case number 10. That is the case of 73-year-old male who complained of pain abdomen, and the provisional diagnosis were renal cell carcinoma and transitional cell carcinoma of left kidney. Nephroerectomy specimen was sent for analysis. So this was the section studied. So here the section studied shows a tumor with adjacent renal parenchyma. So now, higher magnification, the tumor shows infiltrating borders with hyalinized glomeruli within the tumor tissue. So there are also hyalinized glomeruli and atrophic tubules and lymphocytic infiltration seen in the adjacent renal parenchyma. So on further magnification, that is on high power, we see a diffuse, the tumor composed of diffuse discohesive sheets made up of monomorphic cells. These cells are round, monomorphic with indistinct cytoplasm. The nucleus shows post-condensed chromatin and prominent centrally placed nucleoli. These cells are admixed with scattered mature lymphocytes. So at few places, these cells are showing plasmacytoid appearance. So adjacent renal parenchyma also shows dense fibrosis with chronic inflammatory cell infiltration. So to summarize, the section studied shows a tumor with adjacent renal parenchyma. This tumor is composed of uniform-looking atypical lymphoid cells arranged in discohesive sheets. These cells are monomorphic with round nucleus and prominent nucleoli and scant cytoplasm. At places, the cells are plasmacytoid. These cells are admixed with scattered mature lymphocytes. There are many atrophic tubules and hyalinized glomeruli seen. Adjacent renal parenchyma shows fibrotic change with chronic inflammatory cell infiltrate. So my impression will be non-Hodgkin's lymphoma of left kidney. So to confirm the diagnosis, I would like to do IHC. That is, my diagnosis will be NHL, that is non-Hodgkin's lymphoma B cell type. To confirm that, I'll go for CD45 and CD20. And to subtype, so I think it is diffuse large B cell lymphoma. So to confirm that, I would like to go for CD10 and BCL6. Thank you.
Am I audible?
Yes, ma'am.
Okay. So yeah, we'll start with you have already told the case history, which is a 73-year male with a left renal mass.
Yes,
so on cross, we found that there was a 6.5 into 6 into 6 centimeter tumor in the lower pole of kidney, which had a gray tan, fleshy and a homogeneous appearance. This was involving the cortex and medulla and invading into the renal sinus. The renal vein, however, was free. Renal capsule and geroda spacia was also free. The ureter was dilated and filled with blood clot. So now the DD given was an RCC on scan. So how will you know on gross? On gross, usually an RCC will have a yellowish appearance and a very variegated appearance because of areas of hemorrhage. But in this case, it is grey tan, fleshy and homogeneous, which is more commonly seen in lymphomas. So on microscopy, there were sheets of medium-sized to large cells infiltrating the renal parenchyma. I think you have beautifully given the microscopy, so I will not go much in detail. Again, you can see sheets of cells. There is no pattern, like there is no nesting pattern, there is no papillary pattern. And the individual cells have a coarse chromatin prominent basophilic nucleoli. In case of RCC, they would have a eosinophilic nucleoli in grade 3 tumors. And the cytoplasm is scant and there is no clearing of the cytoplasm. Increased mitotic figures are also noted. So yeah, most of you have given a differential of a high-grade NHL. Few of you have given renal cell carcinoma. But I would go more towards an NHL, and I have put markers also more for a non-Hodgkin's lymphoma. I thought that pan-CK would suffice to rule out other carcinomas, and sign up to Pfizer just to rule out a large cell neuroendocrine carcinoma. Now, what all markers were positive in this case? So CD45 was diffuse positive. It was moderate in intensity. pan-CK was negative. So that rules out a carcinoma, and this is a lymphoma. CD20 was diffusely positive. Even CD79A was diffusely positive. So this is more in favor of a B cell lymphoma. Ka67 was high. So it is a high lymphoma. Am I audible?
Yes, you are. Good.
And CD10, if we go according to the Hans algorithm, we first look into CD10. So that was diffusely positive. So this CD10 and BCL6 was also positive. Another marker which was positive was BCL2. We did a CMYC also, which turned out to be negative. So CMYC we do to rule one, CMYC negativity rules out Burkitt's lymphoma, and it also rules out the entity of high-grade B-cell lymphoma with rearrangement of CMYC and BCL2 and or BCL6. So to summarize, this is a left renal tumor with a grossly tan, fleshy, homogeneous appearance, and microscopy shows sheets of large cells with brisk mitotic activity. On IHC, it was CD45 positive, CD20 and CD79A positive, with CD10, BCL6 and BCL2 positive, and a high Ka67 proliferative index. So our final diagnosis here is a diffuse large B-cell lymphoma of germinal center B-cell subtype. So we'll just discuss about primary hematolymphoid tumors of the genitourinary system. These are very uncommon. Primary extranodal lymphomas of the kidney account for just 0.22% of all renal tumors. These are lymphomas are slightly more common in the testis, and nearly all of them are of B-cell lineage. So these are the most common tumors which are seen in the genitourinary system. B-cell lymphomas are more common. They include DLBCL, MALT lymphomas, plasmacytomas, follicular lymphomas, Burkitt's, B-cell, CLL, bar SLL. T-cell lymphomas, Hodgkin's lymphoma, and myelosarcoma are extremely rare. So coming to DLBCL, this is the most common lymphoma of the genitourinary system, and they have a slight male predominance. Usually they occur de novo, and rarely they can occur due to transformation from indolent B-cell lymphomas like follicular lymphomas. And the primary genetic abnormalities seen are rearrangements in BCL2, BCL6, and CMYC. So all these three we can see on IHC. What are the prognostic predictors in DLBCL? As you know, the Hans algorithm uses CD10, BCL6, and MUM1 to subtype the DLBCLs into germinal cell B cell type and the non-GCB or the ABC type, the activated B cell type. Why we need to categorize them, subtype them, is because the non-GCP tumors have a poor prognosis. And GCB, if you find a GCB subtype, then they have an added advantage of adding rituximab to the CHOP regimen. So it's called R-CHOP regimen, and it has a favorable prognosis. Also, MYC, immunoglobulin MYC expression and a dual expression of MYC and BCL2, they have a very poor prognosis. So anything with a MYC expression has a poor prognosis. Now, what are the key DDs of DLBCL? There is an entity called EBV positive DLBCL. The immunoprofile is similar to DLBCL, but EBER-ish is positive, and on microscopy they may have cells resembling RS cells. In these cases, CD30 will be negative, CD20 will be strongly positive, which is opposite in what you see in Hodgkin's lymphoma. Also, there is an entity called monomorphic post-transplant lymphoproliferative disorder of DLBCL type. Morphologically, there is no difference. Only you have to ask for the history of transplant, and the patient will be taking immunosuppressive therapy. So the etiology is because of this immunosuppressive therapy, it leads to a polymorphic lymphoproliferative disorder, which then turns into a monomorphic lymphoproliferative disorder. It can be of any type, but DLBCL or a Burkitt's type also can occur. Another entity is the high-grade B-cell lymphoma with MYC, BCL2 and BCL6 rearrangement. This entity was added in the 2016 WHO, and the older terminology which was given in 2008 was even longer than this. It was called a B-cell lymphoma unclassifiable with features intermediate between DLBCL and Burkitt's lymphoma. So thankfully it is now slightly shortened, but these are also called double hit and triple hit lymphomas. Double hit is when there is MYC and BCL2 rearrangements, and triple hit is when all the three rearrangements are seen. Another DD is an intravascular large B-cell lymphoma where the large cells are limited to the intravascular spaces. So with this, I will conclude my discussion. Any doubts, you can just put it in the chat box. Thank you.
Thank you, Dr. Vaishna. I think with that, we'll move to the last case. Dr. Agatha, please go ahead and present the case. Number 10, unmute yourself. Dr. Nusrat.
Sir?
Yeah, please
Sir,
share your screen.
I have presented the case, sir. This is my case number 10.
Sorry. Dr. Agatha, sorry. Dr. Agatha Sundari, please go ahead. Dr. Agatha, click on presenter mode. Dr. Agatha, you're not audible.
Yes, sir. Yes, sir.
Yes. Please click on slideshow mode and go ahead.
Sir, am I audible now?
You're audible. Put it on slideshare mode.
Yes, sir. Sir, is it visible?
Go ahead.
Sir? So I am Dr. Agatha Sundari, third year postgraduate from Chettinad Hospital and Research Institute, Chennai. The case allotted to me was case 11. The history we received was a female aged 64 years with choriocarcinoma ovary. So this is it's a low view showing predominantly arrangement in tumor arranged in papillary pattern. This is another higher view showing the presence of multiple papillae showing a hierarchical complex branching and with areas of necrosis. As we can see here, there are pseudoglandular pattern and micropapillae along with papillary pattern and areas of necrosis. These are the small papillae showing hierarchical branching, which are small and complex. And over here, we can see the pseudoglandular pattern. And the stroma shows hyalinized cores. And this is the hyper view showing the atypical cells, which are showing nucleomegaly with increased NC ratio, eosinophilic cytoplasm, some showing prominent nucleoli, and numerous mitotic figures. So based on this, we can give a summary of sections from the tumor shows atypical cells arranged predominantly in papillary
and focally in solid, glandular, and cribriform patterns. The papillae are thin, some are broad, and show complex branching with hyalinized cores. These atypical cells, they show stratification with eosinophilic cytoplasm, nucleomegaly, increase in nuclear cytoplasmic ratio, hypochromatic nuclei, occasional prominent nucleoli, and atypical mitosis, which are around 10 to 12 per 10 hyperfield. There are also extensive areas of necrosis. Based on the above observations, I came to a conclusion of the following differentials. First one is high-grade serous carcinoma of ovary bar fallopian tube. Second is the endometrial carcinoma of ovary. And third differential is the clear cell carcinoma. So a high-grade serous carcinoma of ovary, it can be an epithelial carcinoma with papillary, glandular, and solid growth patterns and high-grade cytological atypia. There are solid masses of columnar to cuboidal cells with eosinophilic cytoplasm and slit-like spaces. They show hierarchical papillary branching with glandular and cribriform patterns and significant nuclear atypia. There can be nuclear pleomorphism with bizarre and multinucleated forms. Prominent nuclei can be seen with high mitotic index. There is frequent necrosis and variable samoma bodies. The positive stains will be positive for Paxid, WT1, and in high-grade serous carcinoma, P16 can be positive. It's positive for ER and focally positive for PR. There can be aberrant P53 expression, which correlates with TP53 mutation. The overexpression is shown as strong diffuse nuclear staining in more than 80% of the cells, and there's a high K67 proliferation index of more than 75%. My second DD was endometrial carcinoma. It often presents at a lower stage, and there will be a background of endometriosis. ER and PR will be diffusely positive. WT1 will be variable with patchy P16, and P3 will be of wild type expression. So this is the tableau column showing the different IHCs in high-grade serous carcinoma and endometrial carcinoma. As we can see, the high-grade serous carcinoma shows positivity for WT1, PAX8, ER, CK7, and can be mutant P53, whereas the endometrial carcinoma shows positivity for ER and it's negative for WT1, and P53 is wild type. The other differentials are low-grade serous carcinoma, which shows minimal nuclear pleomorphism and low mitotic index, less than 12 mitotic figures per 10 hyperfield, and P53 is more of a wild type expression, and P16 can be negative or patchy positive. And my last differential is clear cell carcinoma. It can be associated with endometriosis. It often presents at lower stage of presentation. It can also have a papillary, tubulocystic, and solid growth pattern. It's composed predominantly of clear, eosinophilic, cuboidal, or hobnail cells. It will be negative for WT1-ER, whereas it's positive for NAPSIN-A and HNF1 beta. Thank you.
It was a very good presentation, and you covered all the patterns in this. Let's just have a look at the summary of this case. So this was a 64-year female with the left ovarian mass suspected to be a carcinoma ovary. They had sent this for frozen section for us, and when we saw the frozen, we were also confused as to what pattern this fitted into. We were sure one thing, that it is malignant. So we just gave it out as malignant, and we did not give a categorization. And the surgeon did an extensive surgery, did a THBSO with omentectomy, peritonectomy, and regional lymph node dissection. So on gross, this was a fibril tumor in the left ovary, which had a solid and cystic appearance. And there were large areas of necrosis. That is, these yellowish areas which you can see are the large necrotic areas. And it was adherent to the uterine serosa and directly invading the myometrium. The endometrium, however, was free. Grossly, there was no peritoneal or omental deposit seen. And as you had, as Dr. Agatha had already mentioned, the tumor was arranged in broad papillae, nest sheets, and occasional glandular pattern, as you can see here, somewhat cribriforming pattern. But as we took more sections, we even found that there were areas which had a multi-layered, round to oval cells, which appeared a bit transitional-like. Here also you can see a bit of a clear cytoplasm, and there is a large areas of geographic necrosis seen. The tumor cells had moderate to marked pleomorphism with a brisk mitotic activity. And the invasion was more of a pushing type, and there were a lot of, they were going as nests. So the differential diagnosis which all of you have given, many of you gave high-grade serous carcinoma, a few of you gave malignant Brenner, few have given endometrioid carcinoma. So we had the same doubt because there were various patterns which fitted into any of these three tumors. So we put a marker of IHC panel, which consisted of CK7 and 20 to distinguish between primary and metastatic colorectal. CK20 will rule out, CK20 will be positive in colorectal. ERPR will be variably positive in the ovarian surface epithelial tumors. WT1, PAX8, P53, and P16 can help to detect high-grade serous carcinoma. P63, GATA3, and uroplakin are usually positive in malignant Brenner. NAPSIN-A will be positive in clear cell carcinoma. So what was positive in this tumor? CK7 was diffuse and strongly positive. CK20 was negative, and P63 was also negative. So this ruled out a urothelial malignant Brenner. Uroplakin GATA3 was also negative. Now, what other markers were positive? WT1, PAX8 was strongly positive. ERPR also was strongly positive, and P16 showed a diffuse block-like positivity. P53, however, was a wild type. So the other markers are supporting a high-grade serous carcinoma, but P53 was wild type in this case. It did not show a strong positivity or neither a null type or neither a cytoplasmic positivity. So to summarize, this was a left ovarian solid cystic tumor with necrotic areas, and on microscopy, a variety of patterns in terms of papillae, nests, glandular, and focally transitional-like pattern was also seen. On IHC, it was CK7 positive, ERPR positive, WT1, PAX8, and P16 positive. P53, however, was of wild type, and it had a high Ki67. So our final diagnosis we gave as high-grade serous carcinoma of set pattern, that is solid endometrial-like and transitional pattern. I was very happy that quite a few of you had mentioned this in your diagnosis. So what is the set pattern? These usually are, have a solid pattern, glandular endometrial-like pattern, and a transition cell-like pattern. And they are usually associated with homologous recombination deficiency. These tumors often display geographic necrosis and a prominent lymphocytic infiltrate. Approximately 90% of high-grade serous tumors demonstrate nuclear expression of WT1, which is usually diffuse. So in our case, WT1 positivity rules out endometrioid and also rules out transitional cell, that is malignant Brenner. Approximately 95% exhibit an abnormal pattern of P53 expression. This is seen as either a strong diffuse staining in at least 80% of cells, or it may be a null expression with an intact internal control, and rarely a diffuse cytoplasmic staining with weak nuclear staining. So what is the prognosis of high-grade serous carcinomas? More than 95% of patients have extra-ovarian disease at presentation. They have a median 5-year survival rate between 15 to 55%, depending on the stage and degree of debulking done. And despite the high initial responses to chemotherapy, in about 65% of patients, they recur. And clinically, high-grade serous carcinomas can be classified into platinum-sensitive and platinum-resistant cases. Platinum-sensitive have a favorable prognosis. Now, homologous recombination deficient tumors are more platinum sensitive. So, homologous recombination basically is, it helps in the repair of DNA damage, double-stranded DNA damage. Also, BRCA germline mutations, if they are present, signify a better prognosis. Now, there are these PARP inhibitors, which they target the DNA damage repair process, and when they are given as a maintenance therapy, they significantly improve progression-free survival for both BRCA carriers and women with homologous recombination deficiency, thus providing the largest magnitude of clinical benefit for patients with germline mutations. So as pathologists, we are not going to just stop at the diagnosis. We have to go one step further and suggest prognostic markers and molecular testing. I think that will be the norm in future, because right now there are a lot of targeted therapies, and the specific markers which like PDL1, which will help in targeted therapies for the patients, and it will improve the survival rate for the patients. So this is the end of my discussion. Thank you. Any doubts, you can please put it in the chat box.
Thank you, Dr. Varsha. I think with that, we come to the end of the slide seminar. I request either Dr. Ravi Kumar sir or Dr. Vani Ravi Kumar ma'am to deliver the closing remarks before we close the session. It was a very fruitful discussion. I think we all have learned a lot. Dr. Santosh, so even you may deliver the closing remarks if you want. Vani ma'am, you are live.
Yeah.
Please go ahead.
Am I audible?
Yes, you are. Yes, you are.
Yeah, so we have come to the end of the slide seminar, which was contributed by RV Metropolis Lab, Bangalore. And I'm first of all apologize for overshooting the time by about 23 minutes, and I hope you would tolerate that. And I thank the participants, especially the postgraduates from different medical colleges, for not just an active presentation, but for a superb presentation by all of you. Well done, keep it up and keep up this momentum. And I also thank all the audience, the senior pathologists, CSBR sir and other senior doctors, as well as the students who have logged in, and they have spared their precious time to attend this slide seminar with their interactive discussions and to keep it very lively and active. And finally, I thank KCIAPM, I thank Dr. Aditya Agnihotri for so wonderfully organizing this entire online session and making it a very a savvy slide seminar, a very tech savvy slide seminar, which we are very proud to see that we have come to this level of doing the slide seminars. And I hope you give us a chance again next year to conduct a similar slide seminar. So thank you all once again, and bye. Take care. Have a great weekend.
Ravi Kumar sir. So, Ravi sir, final remarks from you so that we can close the session.
I think Dr. Vani has, spoken. So thank you so much. I think I should thank everybody, including yourself and all the members and our own, colleagues who have taken so much of interest in making this, whatever the best efforts to ensure that, they take care of all the slides in a very serious manner so that, the presentation will be good. So thank you so much, and all the best to everybody, and hope they'll have a nice, weekend. Thank you so much.
Thank you, sir. The cases were wonderful indeed. And I request the audience to download the Android app for KCIAPM School of Pathology that we have released recently, so that the participation in the slide seminar is a lot smoother. And we look forward to having you all live next month for the slide seminar being organized by SGM College of Medical Sciences and Hospital on 18th of May. So we'll be releasing the slides in a couple of weeks from now. Have a look at them. Please share your results, and we look forward to the discussion next month. Until then, see you. Thank you. So we'll be closing the session now. The slides will be available for viewing for another couple of weeks, so please go ahead and view the slides again if you want to. Thank you. We'll be closing the session now.
Thank you. Thank you so much.